The theme of the whole conference here is how you have your leaders constantly focusing on results that makes all the difference in the world. My feeling is that kind of strategies that people have are pretty common around the country, that in fact, strategies don't differ that much, but what really differs is how well you execute your programs. And a key part of that is how your leaders focus on the objectives. What we really focus on is how you get your leaders to focus on key results. Now, we got to this. We have, at Penn, as you probably know, we have a great business school called Wharton. So when we first started our version of this at Penn, we relied first on integrating with Wharton for executive education. But we found quite quickly the kind of curriculum that they offered was not specific enough for what we wanted to do. And so we migrated fairly quickly to what you'll see the results of today. And my phrase over this, for this is to involve the leaders in really taking on real-life problems that go on inside the setting. And my little phraseology for this was, we teach them on Saturday what we wanted to do on Monday. So basically, you constantly want to be in the middle of the kind of the problems that you have. So whatever is going on in any of your health systems or any of the areas you have right now is so critical in the leadership development program to really be focusing on the issues that they have. Now, one of the challenges I have found is working with physicians and nurses is sometimes you really have to give them examples from healthcare. Kind of the traditional curriculum that one gets, let's say from a Wharton business school or the business schools around the country, they'll give you examples from finance or from retail and merchandising or so forth. And I have found that giving them examples, this is what you do in the ICU, this is what you do in your retail clinics if you're doing that, is what you do in your patient-centered medical homes or wherever else you're locating your care. Those examples are critical. You have to link these strategies always to resource allocation. This phrase I borrowed from a trustee of mine when I used to be at the University of Chicago. And it says, you know, when people say it's not about the money, it's really about the money. And I don't mean we're not for profit institutions, but resource allocation is always a critical part of whatever you do in any kind of organization. And generally, a lot of the controversies people have, since especially when you work in a hospital, everybody thinks they're doing good. Nobody thinks they're in it for their mission is totally aligned. But there's still the question of how you get resource allocation targeted appropriately to the kind of objectives that you have. So one of the things that we always teach, and you'll get some examples of that from Beth and Michele and others, is how to tie resource allocation to kind of leadership development and constantly teach people how to do that. We use our leaders as teachers. All of us do the teaching inside our academy. So it's not just professional staff. We do have professional staff, but all the leaders have to teach. And that has the advantage of both having the frontline leaders that we want to develop see what our values are and how we execute it, but also when they give us problems, we can say, here's how we think about those kind of problems, and we can go back and forth. It also allows us to really do talent spotting, because when the people you'll be seeing in a moment and I teach, we might have 50, 100 people in the room like this, and just based on the interaction with them, we get a really good sense of who's in the pipeline and who we want to develop. So that kind of constant interaction between the teachers as leaders and the people who are coming up the system is of critical importance. You have to be relentless in constantly focusing the organization on what you want it to get accomplished. Secondly, I grew up in New York, and in that era, whenever the local utility was digging up the streets to make some kind of improvement, they always put up a sign that said, progress is our most important product, as a way of kind of getting you to ignore the fact that the street was dug up. I always use that progress as our most important product, and in universities I always feel process is our most important product. And what I try to teach people in hospitals, you can't be lost in process. Process cannot be the most important product. You constantly have to focus on outcomes. So what we really try to do in our academy, both in Chicago where I used to be and at Penn now, is constantly teach people to focus on outcomes and how to get to outcomes. In fact, work backwards from the outcomes you want to achieve to the kind of training process that you want. Always keep remembering, because one of the things is always, when you take courses on organizational behavior or in business school and so forth, they always tell you the difference between a for-profit institution and not-for-profit institution is for-profit institutions have a clear measure of outcome, e.g., how much money you make, bottom line, et cetera, and so forth. In places like schools or universities, hospitals, and so forth, we have so many missions that we tend to think, I'm doing this, and doing that, but you get lost in kind of what your outcome has to be. So one of the things we try to relentlessly do, we target our outcomes and we measure them over and over again to make sure that people understand what they are. But one of the things we saw is that the number of people who are dying in our hospital was greater than was expected based on risk adjustment. And over the course of the last 6-7 years, we got that ratio from 115 down to 0.65. So basically, we're running 33% better than one could expect. And that leads to, this year, 625 people being alive, that if we had not maintained our previous processes. Furthermore, and Beth will speak about that in a moment, we've really focused on what's called the patient experience. We've increasingly learned, especially now with HCAP scores being part of pay for performance, you have to focus on how the patient experiences your care. So great improvement in that as well. You'll see more of that in a moment. And our financial results, given our focus on bringing down mortality, improving infection rates, and improving the patient experience, I don't want to tell all our creditors here, but we still run about a 12% margin or so, well above the national average. It's this kind of ongoing focus on outcomes that we think is critical in any kind of setting such as ours. And then to use instruments like the academy and all your managerial structure to constantly teach people how to focus on how to get there. And what we've learned is always be immersed in the moment, as whether it's Ebola in the last month or two, infection rates over the last 10 years, customer satisfaction, patient satisfaction, reconfiguring care. You constantly have to take those lessons, teach people how to address it, and as I've said, teach them on a Saturday what you want them to do on a Monday. Make it very real for them at all times. You want those people who are running those units, your nurses, your executive directors, you want them coming to what we call the academy to say, put in Epic, train these new doctors that we just brought into our system, bring down infection rates. They have to be the linchpin in your performance improvement strategies. And when your organizational development people, your learning academy, whatever you call them, are seen as the people who make that happen, then your academy is in great shape.
I'm going to talk to you a little bit about our quality leadership alignment. And we at Penn have developed a CMO-CNO alliance, which I think is a really good example of leadership alignment that Penn Medicine has worked to achieve now. That was conceived in 2006, and it was conceived by our CMO, who's still our CMO, Dr. P.J. Brennan, and Dr. Victoria Rich, our former chief nurse executive. And our purpose was to develop a blueprint for quality that you see up here on the screen that really represented our comprehensive roadmap or strategy for how to achieve really stellar clinical outcomes and patient experience. The blueprint that you see on this slide represents our third iteration of our strategic plan for quality, safety, and experience, and it really reflects the input of over 600 stakeholders, both internal and external from Penn. It represents, when we first started this, we talked to 50 people. Now, the third time around, we talked to over 600 people. And the blueprint is composed of our overarching goals, which are not so similar probably from most hospitals and health systems represented here, as well as imperatives. Now, our imperatives are, in a way, our hypotheses, our theory of the cause of how we are going to get to the outcomes that we want to achieve. So I'm a big believer in beginning with the end in mind. We start with our overarching goals. We talk about the major imperatives, and this blueprint represents, I think, above all, a progression to thinking about not just inpatient care, but the continuum of care, as well as this concept of value, sitting at the juncture between cost and quality, which has become increasingly important for us as a way to achieve our goals at Penn. So while this blueprint really represented the overall strategy for how we were going to get there, we also needed a more granular approach, kind of the how we were going to achieve this. We were fortunate that we have some good foundational elements. In 2007, we developed through the Blueprint for Quality and CMO-CNO Alliance our unit-based clinical leadership teams, conceived of a physician lead, a nurse lead, and a quality expert. So every unit has a unit-based clinical leadership team. And as well, we had a very robust Penn data store, and we were able to roll out data marts that provided data down to the physician and the patient level for units, services, and lots of other ways of analyzing this. But we still needed to provide these teams with some tools for how to improve and take advantage of this once we gave them the data and the structure. Another good example of alignment was in 2010, our quality leadership and our organizational learning leadership partnered to initiate this performance improvement process that was designed to really embed PI capabilities within the organization, and perhaps most importantly, within our frontline leadership. Now, this approach was delivered within the Penn Medicine Academy, which you'll hear a little bit more from Craig, which is our learning infrastructure developed by our organizational leadership team, and many of them are here in the room, and Ralph introduced them, and we couldn't have done this without them. And let me just tell you a few of the essential elements of this PI process. The first was instruction on specific Lean and Six Sigma improvement tools for intact teams working on real-life problems on the front lines, and we called that action learning. So the two elements were you came as intact work teams and you worked on real problems, and that's how you learned your performance improvement approach. We used this as a rapid experimentation process, and it was a 3-month cohort training and implementation cycle, and that really helped us. When we came out of this end of this 3-month cycle, we would generally characterize the projects as either a home run, and that was something that we wanted to disseminate right away. Another option would be, well, we learned a lot, but we're not quite sure. We still need to collect more data, do a little bit more work, and tweak it. You know, let's keep studying it for maybe another 3 months, but outside of this formal process. And then the third is what we would call a fast failure. This didn't work. And, you know, for an academic medical center, that's not something that's necessarily very easy for people to accept, that this didn't work, and yet that was a good thing, because we learned it fast. You know, we didn't spend 6 months or a year working on something and then say, not for us. So these fast failures really were something I think that characterized and a very important part of our PI learning process. Another good example of alignment was in 2010, our quality leadership and our organizational learning leadership partnered to initiate this performance improvement process that was designed to really embed PI capabilities within the organization, and perhaps most importantly, within our frontline leadership. Now, this approach was delivered within the Penn Medicine Academy, which you'll hear a little bit more from Craig, which is our learning infrastructure developed by our organizational leadership team, and many of them are here in the room, and Ralph introduced them, and we couldn't have done this without them. And let me just tell you a few of the essential elements of this PI process. The first was instruction on specific Lean and Six Sigma improvement tools for intact teams working on real-life problems on the front lines, and we called that action learning. So the two elements were you came as intact work teams and you worked on real problems, and that's how you learned your performance improvement approach. We used this as a rapid experimentation process, and it was a 3-month cohort training and implementation cycle, and that really helped us. When we came out of this end of this 3-month cycle, we would generally characterize the projects as either a home run, and that was something that we wanted to disseminate right away. Another option would be, well, we learned a lot, but we're not quite sure. We still need to collect more data, do a little bit more work, and tweak it. You know, let's keep studying it for maybe another 3 months, but outside of this formal process. And then the third is what we would call a fast failure. This didn't work. And, you know, for an academic medical center, that's not something that's necessarily very easy for people to accept, that this didn't work, and yet that was a good thing, because we learned it fast. You know, we didn't spend 6 months or a year working on something and then say, not for us. So these fast failures really were something I think that characterized and a very important part of our PI learning process. The next slide, I'm going to show you a brief video of a executive report out. So we have teams that go through these 3-month cohort, and at the end they have a report out. So we invite the team leaders, team facilitators, and team members, as well as the entire senior leadership of Penn Medicine. And one of our, Chris Clark, who works for the Penn Medicine Academy, goes through this amazing logistical feat where everybody gets a number and attached to it, a cohort, and we move around the room to listen to up to between 10 and 12 projects in 7-minute cycles, and we have the opportunity to interact with these teams and ask questions. And so I have a brief video of that report out.
And the problem we've identified is that the communication of patient deaths to stakeholders, both internal and external to the organization, have been inconsistent. So with that, we actually went in and developed a few countermeasures to implement into our pilot area of critical care. And these were to create a standardized process to make sure that the discharge was done correctly using Navicare, and to get the nursing supervisors, the NACs, involved in checking to make sure that that is done.
What are the challenges in just rolling it out house-wide?
So you can get a sense of what that's like. So the team members give a little blurb. We as executives, unfortunately, I didn't feel that that's a very flattering picture of me, but I was in there. Then you would have, if we continued that on, you would have seen the COO of the health system in that group as well, and the VP for HR. But it's a very robust dialogue. And the other great thing about that learning experience is the other team members and leaders who they also, when they're not doing their presentation, they rotate and they get to hear what all the other teams are working on. And so it's a real opportunity for both the senior leaders as well as the team leaders to have a dialogue around that. Okay, last slide, and we're here. So we've had really good success with that, and I think a lot of the outcomes that Ralph showed you flow directly from this approach that we've used in the organization. I think the real value that we found is that these teams, these team leaders and facilitators, they bring these experiences back into their organization and start to be able to work on these performance improvement programs in real life. So it's not just a special program, come back and keep doing what you were doing before you went. And so we've trained now over 150 team leaders, team facilitators, who are now working on the front lines in all sorts of different capacities, and have really taken this to heart and love using this and have found this to be a great problem-solving and improvement approach. So you see we launch a new cohort every 100 days, 134 PI projects through this cycle so far, over 1,200 participants, and up on the screen there you can see examples of some of the teams and some of the really stellar outcomes they've achieved that have impacted our value-based purchasing, our payer performance, pay for performance contracts, as well as some of our branding and national reputation around U.S. News and World Report and the like, which we feel are also really important to us.
I vividly remember sitting in my office with my chief operating officer, looking at the latest numbers and saying, we got to stop this. This is an embarrassment, and doesn't represent what we hold dear. So we worked with Judy Schuler, who was head of the academy at that time, and said, this is broken, and we need to really look at this in a different way. So we actually utilized a tool that we had learned in an earlier leadership development course developed by Greg Shea, who's on the faculty at the Wharton School. And it's a work system model. And it's basically very simple in its construct. It just says that you've got to pull on many levers at once for a sustained period of time in order to really get organizational change embedded throughout the institution. So we then said, all right, we're going to work in partnership with the academy. I couldn't do it on my own. I didn't have sufficient staff or expertise to really accomplish this. And so I really took the lead, and we embarked in partnership on a multitude of efforts that included things like changing the way we recruit and screen for candidates, introducing behavioral screening tools into our process. We revamped our hiring and onboarding processes. We created actually what we call the Patient Service Rep Academy, which is something modeled on something the Cleveland Clinic had done. But it is a 5-week training course where we hire for aptitude and train for the technical aspects of the job. And then we hire in fully proctored and experienced people into the roles. So rather than a warm butt in the seat, if you will, who still has 6 weeks of training and getting their security clearance through for EPIC, et cetera, they're ready to go and embodying the values which we're holding out to the organization. We began publicly and broadly publishing our results, the good, bad, and the ugly. I'm a big fan of the wall of fame, wall of shame, to really stimulate a lot of competition amongst our practices. We reinvigorated the rewards and recognitions program to tie into that. So those practices that were making a difference, we brought them forward, gave them visibility, asked them to help us disseminate this more broadly. A lot of that progress came from some of these performance improvement in action teams that Pat spoke to. So we utilized a lot of these other component parts of our training programs to accomplish this. We cascaded the leadership goals that were embedded in the executive management's incentive plans down into every member of CPUP who participated, including our billing managers and our directors of finance. They had equally weighted goals on outpatient experience. We restructured the governance of our board of directors to incorporate frontline physician leadership into helping us really make a difference and engaging them in a really fundamental way in improving the experience. But perhaps the biggest lift that we had was making an investment in our existing managers and staff. With relatively low turnover rates, especially after the economic downturn, we weren't going to change this culture by simply hiring better. It was going to take too long, and in fact, the prevailing culture would have just swamped whatever initial efforts we did through the hiring process. So we worked with our colleagues at the Academy and developed the Penn Medicine, what we called the Penn Medicine Experience. And it was a multifactorial program. Started with a 4-hour course in a classroom for practice managers. We wanted to pull them out of their clinical environment and get them to interact with each other. So it was both didactic and role-playing. They learned specific skills on how to lead for service. They ended up developing individualized work plans on how they were going to implement tools that they had learned and skills. And more importantly, they learned on how to go back to their employees and get them prepared for the training that they were going to undergo. And we framed this not as basically charm school or punishment for bad scores, but as an investment that we were making in them. And I was a very firm believer and emphasized this at every one of the management sessions, which I attended all of them. And I said, look, we are going to make it really explicit what it is we value and hold dear. We're going to reward people for that. We're going to promote people for that. We're going to make it explicit in our job descriptions and expectations. And then we're going to train, we're going to invest in you, and we're going to prepare you to be able to be successful in this environment. And then we're going to hold you accountable for holding your staff accountable. But before we made those first two investments, we weren't going to get to the accountability phase. So following the manager training, we brought in over 2,500 staff to a 4-hour course. And again, this was very dynamic. It was a lot of role playing. It was listening to the voice of the patient. It was engaging them in group dialogue. And they came out with their own work plans on how they were going to implement. We were using Studer's AIDIT tool as sort of the basic construct. We customized it, and we really asked all of our staff to figure out how to customize that tool so they spoke in their own voice. We weren't trying to create a series of robots to go out there in the practices, but how did they implement that? Perhaps the most powerful thing we did was following that 4-hour class, all 2,500 people went through a one-on-one simulation with a standardized patient actor. And I'm going to show you a clip in a moment, but each of the scenarios that were developed, they were developed with the practice manager so that the scenario was based on that subspecialty, on the patients that staff member encountered every day, so that the training tool would really resonate with them.
The doctor is with another patient?
Okay.
Okay. Is there anything else I can do for you? Would
I'm
you like
sorry.
some water?
I'm just really nervous because my husband can't come. He has to be in court today, and it's a big case, and I'm usually not like this, but I'm getting really scared if I get the sonogram, if I get some bad news.
So we ended up, at the end of this one-on-one simulation, both the staff member and the actor graded the encounter, and we used the AIDIT tool. So what behaviors did they recognize, and used that in a very formal feedback way. They compared those scores, and it was actually remarkable. A lot of the staff tended to rate themselves actually lower. They were really focused on what they needed to do to improve. And then there was about a 30-minute coaching session where that patient actor talked about what they felt as a patient. Did they feel that staff member listened to them? Did they react with empathy? What went really well? And where did they feel a little bit disenfranchised? Where did they feel left out of the process, or even angry that they weren't being listened to? And I have to say the feedback from our staff on this was incredibly powerful. Many of them approached it with a great deal of apprehension. They felt that this was a test that they were being set up to fail in, perhaps. Some were even angry about having to go through it. But the response was that this was an incredibly powerful, even transformative experience for them. And to this day, when I leadership round in the practices, people will tell me about their experience and what they are doing differently as a result of that. So we are not done with our journey. As you can see, we're still only at the 73rd percentile, and in an industry that's not traditionally been known for service, that means we are a little bit better than mediocre in a mediocre business. So we are going to continue to push hard. We're working hard on the Penn Medicine Experience 2.0, and we're working continually to how to reinvigorate this in the practice. But the idea is to really try to unleash the talent of the frontline staff and managers so that this kind of alignment with our overall goals becomes more organic and less pushed from the top.
Thanks, Beth. We're in a very competitive marketplace, as many of you are here. Penn Medicine saw an opportunity to leverage its brand as well as its reputation for providing high acuity care by reconfiguring how we use our space and facilities in our 3 downtown hospitals. We wanted to take an opportunity to maximize the tertiary and quaternary referrals to our flagship hospital, the Hospital of the University of Pennsylvania, at the same time increasing the utilization of beds and space at the other 2 downtown acute care campuses. So after much consideration, evaluation, we decided on a plan to move level 1 trauma from the Hospital of the University of Pennsylvania to Penn Presbyterian. This transition we knew it was going to impact every single operating unit at the Presbyterian Hospital, as well as we would be transitioning over 200 FTEs from one campus to another. In driving to success, we realized that we had to optimize our biggest asset, and that is our people. The last 2 years, this has been a huge change management initiative, and we expect and will complete this coming February 4th. As many of you know, trauma requires a lot of special skills. One in particular is around critical care and critical care for advanced practice providers. In our marketplace, and most likely in many of yours, these individuals are not very easy to recruit. And so we developed an on-site skill-based fellowship program where we brought in 9 general med-surg nurse practitioners, and we trained them and we built the skill set that we know that they need to function in the multiple critical care units that will be servicing trauma. And so this is just one example of several where we built talent from within. Next slide. Our flagship hospital is routinely utilized over 100%. It's 100% utilized. The trauma move gives us an opportunity to more efficiently use space, which will further maximize our financial position across the entire system. This allows Penn Medicine to increase our capacity to care for tertiary referrals that are now coming in from what is an expanding Penn Medicine network. We knew going into this that it wasn't going to be easy, and so we set out a 3-year time frame. We started out with a stakeholders analysis, and up front we clearly established some shared goals, actually 2. One of optimizing patient capacity across our downtown hospitals, and the second was to a continued margin improvement, again, system-wide. So this has represented significant change management for us. As we ventured into this, we knew that we would have to merge 2 cultures, and the cultures are still fairly different. Up front, we decided to utilize a collaborative team planning process by bringing together the collective expertise to define the future of care. And the future of care in physical plant construction, team definition and skills, and resource depth and dynamics. We knew that we would not be able to dictate a new culture And so we needed a process whereby we put together leaders from both of the campuses, both organizations, who were in parallel roles. We organized them into teams, and we assigned a member of the OD staff for support and also to guide them through the change management process. This, over the last several years, has served as our framework for driving the change process, defining the future going forward, and also leveraging our leadership development to support strategic alignment.
We focus on 4 key areas of people, service, quality, and finance. Those are kind of our 4 pillars. We develop certain programs beyond that, but as we look in terms of what are those key essentials, whether you want to call them competencies or focus areas for our managers, and all of our classes have some kind of learning lab component. There's either a simulation, there's a case study, there's some kind of action learning project that really helps our managers learn more about the organization. One neat way that I work with our managers is in performance management, and along with Denise Lamara, who to my far left over there is our director for our standardized patient program. We used actually an existing infrastructure of standardized patients and formed actually a management lab. So we use essentially actors once again to play the roles of employees, and not crazy difficult employees, just employees that probably could go from good into great. So we use a morning didactic, and then we actually have a lab afternoon where each participant meets then 3 different employees who have a performance issue, and they can kind of go through a coaching process the same way as Beth described. Then the real benefit of this is at the end of the process, the actor then provides feedback to the employee about how they did. They get a standardized grading form that's fairly extensive, along with qualitative feedback that allows them. They also can go back and review their videotape after the class is over. And I'm going to show you a very brief summary. So this again is using the existing function within our School of Medicine around standardized patients.
So what's your take on that? Where are you at with, your response to her? Did you think it was appropriate, inappropriate, kind of what was going on?
Oh, I absolutely think it's appropriate. I mean, I did say please, but I don't want to disrespect anybody's time.
Right.
I respect everybody's time, short, to the point.
So that's a scenario where there's probably not anywhere in your world that was an overeager manager, overeager employee who actually she does her coworkers work for them because they're not as good as she is. And the manager has to kind of go through a diagnostic and trying to figure out, was it something, what can be changed, and how to help the employee get better. So that's again a great part of my job in working with our managers and helping develop. And some of the folks that do the work with us are to my left also, so make sure that we acknowledge them, but would love to hear any questions that you might have.